Okay, it's 4:01, so we're on Eastern, so we're going to get going just to make sure that we have time to do what we need to do. We're expecting a bit more than 100 people, so I think we're almost at the number of people we're expecting. So thank you everybody for joining us, and thank you in particular to President Brown for suggesting that we do this, and to Karen Engelborg and Steve Hall, who have made it possible, and their teams. So today we wanted to do a relatively brief seminar around COVID-19, which obviously has been dominating our national conversation. And we're going to have three presentations, but really the presentations will be short to leave time for participants to ask questions. For those who I do not know, I'm Sandro Galea. I have the privilege of serving as Dean of the School of Public Health at Boston University. And the speakers will be myself, then we're going to have Ron Corley, who is the director of the Needle and infectious disease specialist, and Professor Patricia Hibbard, who is a professor of infectious diseases, as well as the chair of the Department of Global Health at the School of Public Health. Our sequence is, I'm going to do a 10-minute overview of COVID, really covering the basics. Then Professor Corley is going to talk much more about the infectious disease pathology and talk about the state of the science. And then Professor Hibbard is going to talk about the clinical experience to COVID. Between the three of us, we'll talk for 25 to 30 minutes at most, leaving at least 30 minutes for a question. With about 100 people, we should be able to manage questions. And when after Professor Hibbard talks, I'll direct us how we can make sure that we ask questions so that I can actually moderate and get to everybody's question. So with that said, let me do my introduction. And, let me just move to this. Okay. So as I said, my goal is really just to talk about some fundamentals. I want to make sure that we're all on the same page. I realize that everybody on this Zoom call has essentially been living a world where we talk about COVID all the time. But in the past month, since I've been doing a lot of this, we found that there is a lack of a common language and a shared vocabulary about some of the fundamentals about COVID. So I thought I would do some of that just to set the groundwork. So first of all, what are we talking about? What are the symptoms of coronavirus disease of 2019? And by the way, the term COVID-19 means coronavirus disease 2019. It's COVID-19. It is really a disease that has symptoms that are cardinal symptoms are fever and cough, and then followed by shortness of breath. It is 99+% of cases have fever as their first symptom, followed by cough, fairly regular cough. Of course, COVID comes at a time when the common cold is also around and where allergies are also around. So I'm often asked questions about, this seems like my normal flu symptoms or my normal cold symptoms. And the answer to that, of course, is that one should discuss with a healthcare provider. But broadly speaking, these are the symptoms. Now, there are 4 points I want to make. I want to talk about the numbers first. Let's start with the numbers. This is updated as a few hours ago. There have been 440 COVID cases worldwide and about 20,000 deaths. The number of coronavirus cases is certainly a vast underestimate. It's an underestimate because we only know the cases that have been diagnosed, of course, and we have been all over the world under testing. Number of deaths probably is relatively accurate. Just to give sort of a sense of the number of deaths, 20,000 deaths, that's a lot of deaths. But just to ground it, in the US, in a flu season, we tend to have about 50 or 60,000 deaths. This is worldwide, obviously, what I'm showing you. And in the world, we have about 60 million deaths a year, just to give a sense of how that fits into the global picture. These are the spread of COVID worldwide. We all know that it first started in China, in Hubei province in Wuhan, and spread quickly all over the world with hotspots that went sort of Iran, then Europe, including Italy, Spain, Germany, and now in the US. The spread has been very quick. The first case was December 31st of 2019, and now 3 months in, essentially all countries of the world. I think the last count I looked at, 192 countries have had at least one diagnosed case of COVID. These are the countries with most COVID cases, and I did want to focus on this for a moment because I want to comment a little bit on what we're seeing. So this is the top 5 countries are China, Italy, US, Spain, and Germany. And I would like to draw your attention to a couple of things. First, the first column is number of confirmed cases. We should be clear that the US is on track fairly rapidly to become the country with most confirmed cases. One would expect that to happen in the next week. We're currently at 55,000 cases. China had 80,000 cases. I also want to draw attention to cases per million people. So the US, in terms of cases per million people, actually is the lowest compared to Italy, Spain, and Germany. We're still higher than China. And then I would look at the last column, which is number of deaths. Most deaths have been in Italy, and certainly the case fatality rate, meaning the number of people who have died compared to the number of people who've had the disease, has been substantially higher in regions of Italy. Followed then by Spain, then followed by China, while the US is lower, as is Germany. And I'll talk about the Italy case in a second as to why we think that that's the case with Italy. Now, let's talk about the disease itself. So this is a fairly standard picture for what we know about the disease. The vast majority of cases are mild, 80% are mild. Probably that 80% is an underestimate. We're probably dealing with 90+ % of cases are mild, and probably half of those are asymptomatic, which means people would not even know they had the disease unless they were diagnosed through a test. Under maybe 15, maybe 10% are severe, and then moving on to about 5% critical, needing hospitalization. In terms of the death rate, and this is actually quite important, that the deaths are disproportionately higher as age goes up, and in particular over 80, as you see here, with 15% of cases being 80 plus, about 8% more than 70, only 3% over 60, and then really vanishingly low number of cases as you go down in age. So age is highly correlated with death, and age is highly correlated with death, likely not simply as a function of age in and of itself, but age as a correlate of comorbidity. So just to show you this, sorry, so I can't advance my slide.
Click on it.
No, I've lost control of my slide. Oh, there we go. Here we go. So this is the comorbidity chart. So what I want to do, what you're looking at here is that fewer than 1% of people who have died were not known to have comorbidities. That's the blue bar. But 25% had at least one condition, 26% had at least 2 conditions, more than half had 3+ conditions. So by conditions, we mean heart disease, lung disease, diabetes, dementia, hypertension, stroke. So I think this is important to keep in mind, because I do understand that what is very gripping, and really is in the media, are the cases of, for example, the young doctor in Wuhan, who I believe was in mid-30s, who unfortunately died. Now, we don't know very much about him and his medical history, but assuming that actually he was a healthy mid-30s man who died, that would make him very, very unusual. That the people who are dying from this disease are, they all essentially all have at least one other serious underlying comorbidity. And the reason for the age correlation is because age is highly correlated with these other comorbidities. Now, the question that I keep getting asked is how contagious and how deadly is the disease? And I thought this graph actually captures it well, but it also captures well the uncertainty around this. So what you're looking at on the x-axis is the average number of people infected by a sick person, or the reproductive number. And on the y-axis is the case fatality rate, which is the number of people who have the disease, the % of whom who die. So just to focus for a second on the common cold, you see the common cold at the bottom. For every person with a common cold, on average, they give the common cold to 2 other people. But hardly anybody dies from the common cold, so case fatality is 0. If you look at MERS, which you may remember was a coronavirus that we had a few years ago, you see that the average number of people infected by MERS was quite low, about 0.5, but the case fatality was quite high. 35% of people who got it died. And you can see the other disease. You can see smallpox and measles, etc. So COVID is somewhere in that box. Unclear what the reproductive number is, between 1.5 and 3. Unclear what the case fatality rate is, between 0.5 and maybe 2, maybe 3. Now, the reason this matters is because a lot of the things that we are all living through right now, which is essentially a case example of physical distancing that aims to optimize how we mitigate the disease with a given reproductive number and a given case fatality rate really depends on us having the science that tells us what's the best way of physical distancing at each of these intersections. With a reproductive number of 3, case fatality of 30%, what is the right physical distancing? As you can all imagine, we do not have the science for any of these nodes. We don't have the science for any of them, let alone for the 100 or so nodes of possibilities of where COVID sits. So I just want to give people this because it gives you a sense of how much we do not know and how much that's influencing what we do sort of as we stumble around relatively blindly about how to deal with a disease that we do not fully understand. This now shows the deaths from COVID. And what I want you to see is where we are at as United States. US is the orange line. These different gray lines are deaths doubling every day, every 2 days, every 3 days. And Iran is the blue line, and you see the orange line is us. So what you see is actually our number of deaths right now is accelerating at quite a rapid pace. You can see sort of where we are and why we're heading up, and soon will eventually, I would expect us to overtake Italy. Italy, just a quick note about Italy. We've heard a lot about Italy. I want to be clear that while we keep talking about Italy, we're not really talking about Italy. We're talking about Lombardy. The cases that we're seeing are in Lombardy. But this largely is thought to explain much of what we're seeing in Italy, not everything, but the Italian population age 80 or older is really high. Look how it compares to the US. It's twice as many people in Italy are over 80 compared to where in the US. That actually works well in our favor. There are many reasons why Lombardy is thought to be such a hotspot, but this probably is the principal reason. So those were numbers. Number 3, I want to talk about mitigation. I want to talk about mitigation and what we are actually doing right now to try to mitigate and why we're doing that and some of those consequences. So this is the famous flatten the curve, which everybody knows has become a hashtag, become a meme, which therefore means it's important. But just to explain this for a second, the orange is the typical epidemic curve. It's a typical normal curve, which everybody studied in high school and in college. And what we're doing with the protective measures is we're flattening the curve. It is not clear that we are going to be reducing the number of actual cases, but what we're doing is we're stretching out the cases. Now, why are we doing that? We're doing that because of the dotted line, where the health system capacity is. The point is that doing what we're doing will result in a surge in patients in hospitals, which hospitals will not be able to keep up with. By flattening the curve, we stay under the line. This is right now in Massachusetts, where Boston University is, where I'm speaking from. The hospitals are empty. Hospitals are empty because we've cleared them of elective procedures, we've cleared them of elective surgeries, and we are waiting for cases. So we're going through this period of actually sort of eerily quiet hospitals trying to create capacity for when cases happen, which in Massachusetts probably will be in the next 2 weeks. But that's why we're doing all these efforts. It is less about reducing total number of cases as much as it is mitigating the curve so that our health system can cope for those severe people who get to hospital, which you'll remember is fewer than 5% of people in overall COVID cases. Now, this is something that works to our advantage in the US. This is critical care beds per 100,000 people. We have a lot more critical care beds than other countries. As you can see here, this is something which we can discuss in non-crisis times about the wisdom of it, and certainly in this time it helps us. The number of critical care beds we have are certainly not good enough for the worst case estimates of what will happen with COVID, but we certainly have a lot more critical care beds in other places. Look, in particular, we have 3 times as many critical care beds as Italy. And remember, Italy has twice as many people over 80 than what we have. And then I just want to talk about this, about the consequences. So this is the S&P 500. You all are aware of this. Everybody's sort of following their various accounts on this. But I simply want to make the point that as part of this mitigation effort, we are moving to a period of probably massive unemployment, probably with maybe even up to 20% unemployment that is largely affecting people who are low income to begin with. Just to frame this for a second, about 50% of Americans have absolutely no savings. They actually cannot come up with $400 if they had to. And those Americans are also highly unlikely to have anything like sick leave. And those are the groups that are going to be disproportionately affected by these economic consequences, which will have its own set of health consequences. And another set of the consequences that we're going to be seeing, this is from a study that our group actually had done. I just thought I'd show you one slide. After 9/11 terrorist attacks in New York City, this is the prevalence of post-traumatic stress disorder in New York City metropolitan area. And we can talk a little bit about how to quantify it, but there is no question that there will be a significant mental health burden of coming from COVID and from the economic consequences, likely manifesting as depression, post-traumatic stress, anxiety, increase in use of substances like alcohol and cigarette use. And if anybody is interested in that, we're doing a seminar fully about mental health tomorrow at the school, which is open to everybody. And I just want to conclude with this, this COVID that we're seeing, that we're talking about, it's while it's taking all our attention right now, we should remember that a lot of what we're seeing unfurls on top of other global and national conditions. I just want to show you 2 slides about that. Number one is other diseases. As this goes on, this is the average disease deaths per day worldwide. And COVID is the orange down in the middle. You see that's roughly about, we're having 144 to 200 now deaths a day. I did want to point out that that compares to about 3,000 deaths per day, for example, from tuberculosis, 2,500 from hepatitis A. We had about 700 from swine flu. I don't say this in any way to minimize what we're going through. We're going through a truly terrifying period, and we'll hear more and we'll discuss more. But it's good to remember to keep this in perspective about the underlying state of the world that is on which this is overlaid. And then the other, in my last slide, that I want to point out as to the national conditions on which COVID is happening, is COVID is happening on national conditions of very poor national health. We as a US, this is life expectancy at birth, comparing us to other high-income countries. We, broadly speaking, have given up about 5 years in life expectancy compared to other high-income countries. And we've also created enormous health divides, and we have underinvested in the structures that support our health. And all of these conditions ultimately contribute to what we're about to see in the US. So to sum, we're in the middle of a pandemic, very much at the escalating part of the epidemic curve. Next few weeks will undoubtedly get worse before it gets better. It will affect a lot of lives, and not just the disease itself, as well as the consequences that we have to put in place to mitigate the spread of the virus. So with that, I'm now going to go back and turn this over to Professor Corley, who will talk much more about viral pathogenesis. Ron, over to you. Ron? Ron, you're muted. No, do it again. You're still muted, Ron. There you are. Now you're unmuted. Straight now.
Okay.
Very good. You're on. Thank you, Ron.
Fabulous. Okay. Just trying to get shared here. There we go. Sorry. Okay, so a little bit about the background to the pandemic.
Ron, you're not sharing your screen yet.
Oh, it showed shared here. Sorry.
You just go to the bottom to the green arrow.
Yeah, I hit it a minute ago and I thought that worked. So let's see. Are you seeing my screen yet?
No, we're not. Ron, let us take over for you and just
okay,
say next
that'll
slide.
be fine. Thank
just
you.
1 second. Let us take just 1 second.
Yep.
Yep. Ron, just say next slide and we'll advance for you.
Yeah, that's fine.
Good. Go ahead.
That's fine. All right. So, whoop. That's there we go. That's it. So thank you. Next slide. So it's absolutely amazing to me when you think about it. We only learned about this cluster of people, 27 people, at the end of December of last year. That's less than 3 months, and we're already at 450,000 known cases worldwide. Next. The interesting thing is that very quickly it was clear that this was a coronavirus. In an amazing situation, the Chinese were able to isolate and entirely sequence the coronavirus within a 8-day period from the time that at least they announced that that disease was present. Now, what's a coronavirus? And a coronavirus, next slide, is a very large, one of the larger single-stranded RNA viruses. These are viruses that have on them these spikes that make this corona, which is why they're called coronaviruses. You can see the electron micrograph at the top left is the micrograph that was taken of a patient's sample in the Chinese study. And the one below that is kind of the standard, well-done version of an electron micrograph. And then the cartoon shows you that there are what they call 4 structural proteins that make up this virus that surround the genomic RNA. It's a plus-stranded RNA genome. Next slide. Now, coronaviruses are an incredibly large number of viruses. They infect a number of species of animals, including a lot of mammals, a lot of birds. Many species carry these coronaviruses. And until the 2000s, there were 4 human coronaviruses that were known that had been detected as early as the 1960s. 2 of these cause what we call the common cold. 2 of them cause mild upper respiratory disease. And so everyone thought that coronaviruses were just kind of wimpy viruses that caused very little hardship. And then the 2 things that changed that, next slide, was in fact the outbreak of 2 new coronaviruses which had never been detected before. The first, the original SARS coronavirus in 2002. And then the MERS coronavirus, which Sandro already mentioned, that has an ongoing outbreak in the Arabian Peninsula between 2012 and present. And you can see the case counts of both of these, which is quite different from what we're seeing with the current virus, and I'll come back to that. Now, what's interesting about SARS and MERS is that it was already established that these were probably infected humans as what's called a spillover event from animals. Next slide. The SARS coronavirus has been isolated as a bat virus from a number of bats in China that's thought to have infected what's called a palm civet, and that civet infected a single human. And that led to the SARS-CoV outbreak. The MERS coronavirus is thought to originate in bats and is now known to be circulating in dromedary camels, not restricted to the Arabian Peninsula, but found in a number of countries. And it's interesting that those have not experienced an outbreak of this disease. Next slide. So now when individuals started sequencing a large number of coronavirus cases, you can see that this coronavirus, the novel coronavirus in the red, is related to the yellow original SARS coronavirus in a family tree. It is more closely related to a bat coronavirus, and also coronaviruses of what are called pangolins, which I had to look up when I first heard about it. Next slide shows that these are the bat virus that as early as 2017, a coronavirus that was 96% identical to the one that eventually led to the outbreak in Wuhan, had already been identified in a cave in China through a PREDICT program. More SARS-like coronaviruses have actually been identified in bats since then, so there's a large family of these. Since the outbreak, then they've also done a number of coronaviruses, isolated them and sequenced them from pangolins. And so now the question is, was this a bat virus initially? Was it a pangolin virus? Was it a bat virus that infected a pangolin? That's completely unknown. but it almost certain is that this is also a spillover event of an animal virus into the human population. Next slide. So this is what's interesting about all of these RNA viruses. They have a limited number of what are called structural genes. So these are the proteins that make up the virus itself. There are 4 structural genes on the SARS coronavirus genome that was isolated. Now, what's particularly interesting is that there are a large number of other genes, 23, that are non-structural. These don't make up the virus, but these are genes that affect viral RNA replication and processing. They adapt the virus to a cellular environment so they can actually, because these are parasites, viruses are, they actually have to infect and live inside a host cell. And so these are a large number of proteins that make up the ability, contribute to the ability of a virus to infect a cell and suppress normal types of immune responses. Next slide. Now, what's very interesting about looking at these non-structural genes from a virology perspective is that when you look at these outbreaks, the novel coronavirus outbreak accelerated far faster than SARS did. Now, it's almost certain that this accelerated faster because there were a number of cases that were circulating before we even knew about it. But it turns out that there are other interesting differences between the original SARS and now the SARS-2 virus. First is that SARS has a very modest viral load in the respiratory tract that doesn't peak until many days after symptoms begin to occur. And so those are not being spread as easily and as early in infection as the SARS-2. SARS-2, the viral load in the respiratory tract is pretty much the same early in disease as it is later in disease. And it's present in both the upper and lower respiratory tracts, whereas the original SARS virus is normally found in the lower respiratory tract, which is like MERS, as a matter of fact. And so this says that these non-structural genes probably control some of these processes, and we don't really understand that. Next slide. So finally, there are a ton of questions. I mean, there are far more questions than we know anything about. So why do different coronaviruses vary in transmission dynamics and disease pathogenesis? Are these viral related? Do they relate to these non-structural genes? Are these immune mediated? Because we know that a lot of the damage that's done during a viral infection is actually by the immune response that is responsible for that. Now, the other thing we don't know is, are patients immune after recovery from COVID-19 disease? We assume they are, but in fact, we don't actually know that they're going to be immune to reinfection. And if they are, we don't know how long they last. Why is that relevant? It's been shown over and over again that a lot of the common cold coronaviruses, there is some level of immunity, but it wanes very quickly, and people can be reinfected with the same virus. And that we need to find that out for this one. And then if they are protected, what are the correlates? And how do we understand how to use that information to develop better vaccines? Can you tell the difference between an individual that's going to have a very difficult time with the disease versus those that aren't very early in infection, so you can triage care appropriately? So biomarkers are important. We also, because there are no known therapeutics or vaccines to effectively treat the disease, we need to know how to best deal with models that will allow us to test these candidate vaccines. And then again, what are the roles of these non-structural genes? And then finally, we should be learning a lot of lessons from this pandemic to be a little more proactive the next time this happens, because we all know it will happen again. There will be another pathogen X. We need to be better prepared than we have been this time around. Thank you.
Excellent. Thank you very much, Ron. Pat, do you want to control or you want us to control? Pat, you're muted. You're muted, Pat. There you are.
I can't, yeah, I couldn't unmute. Yes, please control it. I think it will be much more time
Sure.
efficient.
Just say next slide and we'll do it for you.
Okay, okay. So I'm Pat Hibbard. I'm an infectious disease physician, also at Boston Medical Center. And what I'm hoping to do in the next few minutes is give you some new information that we have been learning literally over the last 7 or 8 days. Basically, at Boston Medical Center, everything changed last Friday. We sort of moved from preparing for the onslaught. It is now here. And the number of patients who actually have COVID infection and are seriously ill is increasing by leaps and bounds, as well as the number of patients who are coming in suspected of infection. Could I have the next slide, please? As Dean Galea noted, there are well-characterized symptoms of fever, cough, and shortness of breath. Next slide, or next, move forward, please. The Wuhan series, one of the published Wuhan series of around about 200 patients showed that not everybody has fever, not everybody has cough, but as Dean Galea said, about 98% have either fever or cough. About 30% complain of fatigue and muscle aches that are very similar to flu, and 31% or so have a sore throat. Move forward, please. The thing we have to worry about is if anybody moves from fever, cough, fatigue, or muscle aches and sore throat to feeling that they are having trouble breathing or are short of breath, or somebody else finds that they're confused or can't be aroused, that is a time to immediately get medical attention. So it's not necessarily that fever, cough, fatigue absolutely means you have to rush to the doctor, but the second shortness of breath occurs, it's time to move. Next slide, please. This is the idiotically complicated algorithm that we have at Boston Medical Center to figure out who should get tested. Because clearly we now have a test for coronavirus, but as everybody has been hearing, there have been a lot of problems with it. You can see on the left-hand side, it basically starts with the question, do you have a fever or a cough? If you have neither of those, then the next question that obviously can't be done outside a healthcare facility is how much oxygen is in your blood. But let's go up into the second column. If you have a fever or a cough and shortness of breath, or are age greater than 65, basically you need a test for COVID. And people who also have high-risk conditions, and these are the conditions that Dean Galea mentioned before: chronic lung disease, chronic heart disease, low immune counts if they're HIV infected, diabetes, hypertension, etc. These people all need tests. Not everybody else who has just a fever or just a cough needs a test. In an ideal world, we'd love to test everybody, but as you've all been hearing, we've had a huge backlog of our ability to get access to testing. It is now improving, but believe it or not, I have 2 patients on my service right now who I've been waiting for 7 days to figure out if they have COVID infection. That means they're on isolation, blocking a room, and maybe they don't have COVID, and I don't really know what to do with these patients because I can't safely take them out of the room. So the bottom line is, although we'd love to test everybody, there are people who are at risk who need to get tested, and particularly when there are high-risk conditions or shortness of breath. Next slide, please. Treatment has received a lot of attention in the press. As Dr. Corley said, there is no proven therapy that is effective for COVID-19. There's a lot of buzz about chloroquine, hydrochloroquine, and azithromycin. I can't go into a lot of detail, but I just want to let you know the difference between chloroquine and hydrochloroquine and why it's important. Chloroquine is an old malaria drug, been around for donkey's years, and the problem is it's toxic. Therefore, a less toxic version of chloroquine was made, hydroxychloroquine, and this is now a standard medication used for some rheumatologic conditions. So there is a population of patients in this country who are relying on hydroxychloroquine for treatment and prevention of flares of their rheumatological disease. And now they're scared to death that people who think chloroquine or hydroxychloroquine is effective are going to take their supplies. Azithromycin is being recommended in addition to hydroxychloroquine and azithromycin based on an absolutely problematic study coming out of France, where the end point of the patients who received either hydroxychloroquine alone or hydroxychloroquine and azithromycin was whether or not they got rid of virus in their nose. That does not tell us whether or not it actually improved clinical outcomes and took care of patients who are getting seriously sick with lung disease. There are two other drugs that you may hear about that may have activity, but neither of them are known to at this stage. One is called remdesivir. This was being developed to treat Ebola. It is now being evaluated as a treatment for COVID-19 and is barely available through what we call compassionate use, very hard to get, and needs to be studied in clinical trials. Tocilizumab is, or Toki as we call it now, is a monoclonal antibody that tries to deal with the terrible inflammation when people are starting to get really, really short of breath and need to land up on a ventilator. It is also another rheumatologic drug. There is a very short supply of it. We have just a few doses at Boston Medical Center, and therefore trying to figure out who can benefit from this the most is very, very tricky at the moment. There are many other therapies, many mechanisms, and instead of people just panicking and getting these medicines, we really have to actually study them because many of these medicines have significant toxicities. And as I noted there, we are now starting to see some studies that are telling us that other therapies are not effective for COVID-19. Next, please. Everybody really wants to know how bad it is if you get severe disease. And the bottom line is we cannot answer this question yet. We still don't really know how many people are infected in the US or in the world in general. So although people are playing around with estimates of 5% or so, I suspect those estimates are much higher than will eventually turn out to be the mortality rate. But I think you can see from these curves, you just can't rely on the data that we have right now. Next slide, please. Are we learning quickly enough from Europe? And the answer is probably no. We know that obviously things are changing and the rates of increases in places like Italy and Spain are frighteningly high. But look at the dates. We have had so little time to learn from any of the clinicians in Europe about what the warning signs are that somebody's about to get very sick. So we're not able to learn as we wish we could from Europe. And some data is coming out from China, but it's slow. Next slide, please. Where are we today in Massachusetts? Everybody knows we're over 1,000 cases. We've had 11 deaths so far. Move forward, please. And in this next slide, I think you can see the number of tests are increasing dramatically, but still we are not getting turnaround in 1 hour or so. That's what we really need in order to move forward. Next slide, please. This slide also shows the age range of the people in Massachusetts. And I think one of the striking things about this age distribution is that other than the under 19s, which is that tiny black slither at the top, almost all other age groups have a fairly large number of people in that age group. So this is indeed infecting people across the lifespan. And one of the things we don't know yet is whether or not the virus that we are experiencing is somehow acting differently in the United States. Next slide, please. Where could we be going in the United States? Well, people are modeling this like crazy, as I'm sure you can imagine. The current upper and lower limits of the number of people to be infected with this outbreak are projected to be between 160 million and 214 million, with 2.4 to 21 million hospitalizations. And Dean Galea has already put that in perspective in terms of the number of beds that we have available. Deaths could be as low as 200,000, but could be as high as 1.7 million. And being on the front lines, I can tell you the things we're worrying about terribly right now is we need supply chains so we can get surgical masks, those really good, what they call N95 masks, which we must use when we go into a room with a corona patient. We must have personal protective equipment to protect the patients and to protect the healthcare workers. Today, we're starting to hit a crisis in ventilators at Boston Medical Center. We're still struggling with lab testing and lab testing supplies. And the new thing as of today, and I know this is happening across Boston, is we have more and more healthcare workers who are furloughed because they're either being evaluated for infection or have significant symptoms. So we are really in the time period where something has got to happen, and it has to happen fast because it's going to get worse over the next 2 weeks at least. Next slide, please. I'm not going to waste any time on what's being publicized already, but prevention is at least something we can do, and the recommendations and the social distancing and staying 6 feet away from people is a good idea. Next slide, please. I'm done.
Thank you very much.
Back to you, Sandro.
Very good. Thank you very much, Dr. Hibbert, and thank you, Dr. Corley. So we wanted to leave at least 20 minutes for questions. There are two ways to ask questions. One is you can chat. You can put in questions in the chat at the bottom of your screen, and the other one is you could raise your digital hand. To raise your digital hand, you can go to participants, and you can simply raise your hand there, and I will try to triage questions. Let me go to some questions that have already been asked. Just for people to see it, there's been some requests for slides. We sent you a link to slides. This whole presentation will also be archived on our website, so you can actually go and get the whole presentation for the website. So let me start with the questions. The 6 foot distance rule accurate? Could it be too low? The answer is absolutely. A lot of these things are actually fairly arbitrary that we've come up with. Whether it's 6 feet, whether it's 8 feet, whether it's 4 feet, there is no science behind this. And one of the things that has characterized this whole presentation is this whole COVID-19 pandemic is it illustrates how much we do not know and how important it is that we do the science around it. A question about vaccine strategies. Ron, maybe I can ask you that. Can you address vaccine strategies at the moment?
Yeah, so the first vaccine that I know is being tested is the one that is an RNA vaccine that was made very quickly. It's based on the science of taking the sequence of the spike protein and creating a messenger RNA carrier and then using it as a vaccine strategy. It's currently being used in phase 1 clinical trials. Other people are taking a different approach of taking different types of viruses and putting spike proteins on those and using things like known effective vaccines. For example, measles is a fabulous vaccine. The yellow fever vaccine is a fabulous vaccine. You can actually repurpose those and substitute components of the spike protein from coronavirus. And all of those are being tested as well. So there's a lot of activity in that area.
There's a question about, I'll combine two questions. Reliable idea of lifespan of virus on a surface combined with how to handle groceries. I get these questions a lot. There have been laboratory experiments that show that the virus can live on surfaces for up to 3 days. Now, these are laboratory experiments. These are virus living on very clean surfaces, aluminum surfaces in the laboratory. It is unlikely that the virus lives that long in the wild. The advice for things like handling groceries is to patronize places which are taking it seriously, which are being careful with their employees, making sure they isolate employees that have the disease, and to wash your hands very thoroughly. Today I had somebody ask me, should I wash all packages I get from the grocery store? To which my answer is sort of super hard to do that. And I think it's good to be rational and to make sure that we patronize stores that are taking this seriously. Pat, there's a question for you about remdesivir. Has it shown promise in clinical trials? And also, what about the use of plasma from previously infected and recovered patients?
Remdesivir was found to be ineffective for Ebola recently as an example of its effect on a virus. And all we have right now is minimal compassionate use data on remdesivir. And I know trials are starting, but we do not yet have any relevant information. And I'm so sorry, I'm blocking on the second question.
The second question was a plasma from previously infected patients.
Yeah, I think there's an awful lot of interest in doing essentially antibody transfusions from somebody who has recovered from coronavirus. It seems highly likely that that would be effective. It's just there's no system in place, no protocol in place yet. But I think that makes a heck of a lot of sense. Trying to scale it up would be very tricky, though.
Pat, can you, one more thing for you, can you comment on the ibuprofen study and the story that's been going around about that?
Yes, unfortunately, the study itself has not yet been published. These refer to COVID patients in France who received ibuprofen, and there were side effects associated with the administration, or at least believed to be due to the administration of ibuprofen. And so the current recommendation that we have at Boston Medical Center is to use Tylenol, acetaminophen.
Thank you, Pat. There's a few questions. I'll take these, then Ron, I'm going to get to you. Asking about, which is the reasonable question, which is the epidemic curve. When might we expect what to happen? It's very hard to say. Both Professors Cordy and Hibbert have referred to a number of modeling studies. I think the best modeling studies in the US suggest that we're 3 weeks away, at least, from cresting in the US, which one might expect then the epidemic curve to go till 2/3 all the way through to the end of April before we start getting down on the other side of the normal curve. The other thing to keep in mind about the US is that the US is not really a country, it's a continent. And we have different epidemic curves in different cities. So it's Seattle epidemic curve is about a week ahead of everybody else. New York might be a week ahead of us. I think Massachusetts, which is where we are, realistically, we're looking at the epidemic cresting in sort of the 3rd week of April. And I reserve the right to change that as the epidemiology changes. And I don't know if Ron and Pat have more wisdom than that to offer. I see them.
No, I think you're absolutely right. The other thing I would add is that the change in the epidemic curve is only going to occur if people continue to practice social distancing, washing their hands, doing all the right things, self-quarantining themselves. If that changes, all bets are off.
Yeah, and thanks for saying that. Yeah, I should have said my assumption in my 2 to 3 weeks to crest was based on our full-on current plan of physical distancing. Right. Ron, separate question for you. Can you comment about the heat question, the warm weather, whether the warm weather will slow down the virus, the the best available insight given what we know now on that.
I have no insight on that we don't know anything. I mean, because other coronaviruses as well as influenza is seasonal, people have predicted that as a respiratory virus, this may be as well. But I don't know that for a fact.
No, I agree with that completely. Pat, can you comment for a second about, there's a question here which is really about the different kinds of testing, about sort of IgG and IgM. Can you comment a little bit about testing to tell us if people had COVID in the past when they test positive versus so essentially tests to tell us acutely whether somebody has COVID versus tests to tell us whether people had COVID in the past?
Okay, so if they had COVID in the past, it would be one of those non-pathogenic or low pathogenicity coronaviruses, unless it was SARS or MERS. What we are doing right now, and those would be IgG tests. What we are doing right now is we are doing PCR tests. So we're actually looking at looking for the genetic code of this COVID-19 virus. The challenges are many different tests looking at different parts of the gene. But in general, I think most of them work pretty well. What is not helpful, though, is if somebody has a positive, they could continue to have detectable virus because we can't tell whether or not the virus is alive or dead, and even dead virus still could have the genetic code that the tests are looking for. Clearly, what we can't do is culture specimens from the patient because that's too dangerous, and we have to do that in a facility like Ron's BSL 304 facility. So the other problem we've got, annoyingly, is the test is not perfect. If you test too early, the amount of genetic material from COVID-19 may be too low, and consequently, we may not pick up the virus on PCR. There are also some concerns about people not collecting the specimens properly, and there have been some issues this week because the swabs that we usually use to get good specimens have been running very low. So that means in some people you might still be worried that if you didn't get a positive specimen from the nose, but they otherwise had every classic manifestation of COVID versus other respiratory viruses, that a negative would not necessarily be reassuring. There is another challenge that you know, clearly if somebody ends up on a ventilator, then it's a lot easier to get specimens from deeper in the lung, but it is also harder to test those specimens because not all the testing systems can test those specimens as opposed to the specimens that typically come from the back of the nose. So those are most of the testing related issues. In general, I think the test is pretty good. It's certainly not perfect. And honestly, at this stage, the major problem has been an availability of first the testing and then getting us the results.
A couple of questions which are political, although they're labeled as not to be too political, but they are political, which is fine. CDC, reliability of CDC, I want to address that. I actually do think that CDC information is reliable and dependable. I think, but I would encourage everybody to go to the CDC for that information and not to have it filtered through elected officials. I think the CDC website is excellent in terms of the information that they're distilling. There's a lot of information on there. I'm often asked, you know, given the amount of information out there, what should I listen to? I would say go to the CDC website. And that is a very different thing than hearing that filtered through a number of elected officials. There's a question about why the US has had such a failure on testing. I'm just going to address this at the top level, just so we don't spend too much time on it. There's been a serial breakdown in a number of steps in terms of making tests available, not just the test itself, also reagents, that it started at federal laboratories, which created a test which was incompatible with what many states needed to do. And then ever since then, it's really been a chain reaction of us not having sufficient tests to meet our needs until such time as it sort of was too late to really implement proper screening with contact tracing as a country. And we could spend a whole other hour on tests, so I'm actually going to just, in the interest of getting to a couple more questions, move beyond that. There's a question about children, very quickly on children. This virus, as we currently understand it, as you've seen, has been affecting children less. Now, Pat did show the changes in Massachusetts with more people sort of over 20, but under 20 remains very low infection rates. It remains unclear why that is. And there was going to be a lot more work to actually get at the bottom of that at the end of it. Let me ask Ron, you one last question, and Pat, you one last question, just to keep us on track, and then just to make a couple of closing comments. Pat, can you comment a little bit quickly about ACE inhibitors on COVID-19, exacerbating COVID-19 from the Nature paper?
Yeah, so the ACE inhibitor story is that if you're taking ACE inhibitors, particularly if you have high blood pressure, you can actually cause upregulation of the ACE2 receptor. And that is one of the receptors that the COVID-19 uses to get inside cells. So it is really mostly at this stage biologically plausible, and I think what would be more dangerous is for people who are on certain antihypertensive medications to suddenly stop taking them. If anybody is on antihypertensive meds and is concerned that they may be ACE inhibitors, I'd strongly recommend checking in with one's primary care doctor. It probably is fairly easy to make a change, but I wouldn't just pull something off.
Thank you. Ron, can you comment on the likelihood of reinfection potentially with strains that mutate?
Well, what's really interesting about this virus, just like all RNA viruses, is they go through a mutational phase. As far as we know, the major code protein that's required for receptor binding varies very little. Surrounding areas do mutate, but the ACE2 binding site does not seem to vary very much. So my guess is that that is not going to itself lead to a higher rate of reinfection later. I think what may lead to a higher rate of reinfection is that if we don't have lasting immunity as a result of an infection, and we just don't know that yet.
Thank you, Ron. Let me just, there's one last question, which I think is a good last question, which is, sort of what's the bottom line? How do we simplify the message? And I think the bottom line is as follows. This is a coronavirus. It's a novel form of coronavirus. It is a pandemic of a novel form of coronavirus, which has high infectivity, sweeping the world very quickly. There's probably relatively low case fatality rate when all is said and done at the end, but it's very infectious. It will end up with ultimately millions of people dying at the end of it. But ultimately will remain a small fraction of the number of people who die every year in the world. Having said that, it is novel, as a result, reasonable for us to be quite concerned about it. It was going to add a burden of morbidity and mortality that we did not expect. And perhaps if nothing else, it shows us how vulnerable we are to these to pandemics like this, to the potential for another pandemic of an even more pathogenic virus that can emerge. We do know there will be another pandemic. The question is only of what virus and when it's going to happen. So perhaps from all of us, this really is a wake-up call. For those who are interested in more, this presentation will be posted on the School of Public Health website. You can also go on there and you will find a longer version of the seminar that we did that was about 2 hours with a few more speakers. If people want to get into more depth. That was about, I don't remember now, 2 weeks ago. The time has been blurring, so some things are a little bit out of date, but the general principles remain roughly the same. If anybody's interested in mental health consequences, we're doing a seminar tomorrow at 4 o'clock specifically on mental health consequences. There's also on the website. And next week, for those of you interested in the political discussion, there is a seminar on the political discussion. Thank you again, Professors Cordy and Hibbert, for joining us. Thank you, President Brown, Karen Engelborg, Steve Hall, Susan Richardson, for setting this up. And thank you, all of you, for your engagement, everything you do for the university. Everybody stay safe and stay well, and have a great afternoon.
And you all too.
Thank you.
Ditto.
Thanks, Ron. Thanks, guys. Hey, guys, have a good day now, eh? Go get that corner.